All right, so now we're going to go ahead and get started since it's 10:55. But thank you all for returning promptly. We will now move on to our second portion of our speaker session with the topic of cancer disparities. Please welcome Dr. Sora Tanjasiri, a professor in the Department of Health, Society, and Behavior in the program in Public Health, and Associate Director of Cancer Health Equity and Community Engagement at the Chow Family Comprehensive Cancer Center and at the University of California. Her research focuses on community health promotion to reduce cancer health disparities among diverse populations, particularly among Asian Americans and Pacific Islanders. Her work applies community-based participatory research to tobacco prevention and cessation, cancer early detection and survivorship, and she has also served as PI or co-PI on over 24 extramurally funded cancer-related studies, including principal investigator of the 4-year NIH P20 Cancer Health Equity Research Partnership and the 2-year DHHS OMH Health Equity and Literacy in Orange County.
Hi, everyone, and thank you, Brittany, for that kind introduction. And thanks to ESG for inviting me to come speak with you today. It's really is a pleasure being able to interact with students and hopefully share some things that might be of interest to you. I'm going to go ahead and share my screen first. So as Brittany said, my talk is on cancer health equity. And I wanted to start by saying I was really interested in the sessions that we previously had today, thinking about wellness and thinking about the reasons why we go into public health. And I can tell you that for me, a big passion was similar to the things that you shared. For instance, wanting to really make positive impacts in communities, wanting to be able to use my skills and interest in ways that can benefit large numbers of people and populations. And one thing I would add to that list, and I think it really is key to the wellness in my work, and that what brings me joy is the ability to collaborate with cancer, people who are affected by cancer, collaborate with communities that are at risk for cancer, but also with leaders, et cetera, who have a wealth of knowledge and expertise. So the work I do is really an amalgamation of everything that I've kind of learned along the way, and things I present to you today aren't necessarily the work of me solely. In fact, everything is work that has been shared and collaborated with. Okay, so I thought that maybe I would start, and let me make sure I've got a time check here where we are. Okay, with sort of my own journey, because I think that much like the speakers who have talked before, we come to this work deeply informed by the experiences we've had. And, you know, we all have skills, we all have knowledge, et cetera, but those experience shape the ways that we look at public health and the things that we offer and provide and contribute to the field. And I hope that is the same for each and every one of you. So I loved how Dr. Jackson talked about she was a late millennial. I'm a late boomer. And so I grew up in a time when Asian Americans there was really only one narrative of Asian Americans, and they were successful, whiz kids, could do no wrong. Why couldn't every other ethnic, racial, fill in the blank group be like them? And there was a reason for this. This was the narrative really put out there by media, by politicians, by data. Everyone looked at the things this way. Well, during that same time, I also had the opportunity to work for several years in Koreatown in Los Angeles at a place called Koryo Health Foundation. It's a community clinic that offered prenatal care and And during that time, I witnessed firsthand the LA uprising in April 1992. And I show in particular this picture because what we know about the uprising, it was not just one event. You know, even though we talk about the Rodney King trial, it was born out of years of strife between communities fighting for what little resources were being offered to them by government, by funders, etc. And so this is a picture of Koreatown. which, by the way, is a very diverse area. It's made up of Asian Americans, Latinos, immigrants, refugees. I mean, it's a very diverse area. But what you see and what the narrative was businesses were burning down in due to the anger of the city in the outcome of the Rodney King trial that found four police officers innocent of beating him. Um, and you see the businesses burning. And where are the police cars? The police cars are around the perimeter, trying to keep people out and trying to keep the looters and people who are burning in. This is not law enforcement. This is, I mean, for lack of a better word, this is sort of a quarantine and let people who are inside, you know, bear the brunt. And that deeply affected me. I was there in the clinic, and we went home, and I watched my communities and the people I serve really suffer. Nearly the same time, a book came out called My Country versus Me, about, in this case, a Chinese American engineer, researcher, scientist who was accused of being a spy for the Chinese government. This also deeply affected me because the same thing happened to my family. And not only that, not only was my family told, wait a minute, you do not look like an American. Have you been spying? You might need to leave. But my family members were also being told, you know, you don't look like a someone who could be working in our company, and you know, discrimination, ageism, all these things were happening, and I saw my family and my community deeply suffer. I have spent the remainder of my life um, working on my own skills and my own, if you went, my own, you know, mental well-being in order to channel that in ways that can be for good. And it has been an absolute struggle. And I love the fact that people have shared, you know, we all go through this and we all need support. One of the things I'm very proud of is I was very lucky when I was doing my master's in public health that I met someone from what has become this group, the Orange County Asian Pacific Islander Community Alliance. And this is just an example of the fact that I found a community and a group of advocates with whom I deeply related to and have been now working for over 25 years to support their work in health, in wellness, in advocacy, youth development, workforce development. And you can see there's an old picture of me when I had black hair, but I've been devoting my life to it. And my hope is that you find your people in your journey in public health, because has been nothing more gratifying than fighting for things that we believe in with people who are of like mind and like spirit. I thought I'd also share that, you know, I didn't come to this work just poof, you know, here I am, a researcher. But my journey was also a little meandering, and I'm always really astounded at folks like, you know, all of you in ESG who have found public health so quickly. I actually started I'm the eldest of a child of immigrant parents. I was med school bound. I had to be going for med school. And so I picked biochemistry as my major even before I went to school at UC Berkeley. I'm going to go to med school. And then halfway through, I thought, no, I don't want to be in med school, but I don't know what I want to do. I was lucky enough to take a public health class and then do a independent studies project with that professor, and graduated thinking, maybe public health. But I needed a little bit more time. So I took a year off, which I now call my gap year, to really get a little bit more experience, to take the GRE, to prep myself for what, you know, I thought would be a viable career. And I was so excited when I got into UCLA and did my MPH. Now, I took then 2 years off before I did my doctorate in public health, because I thought, well, I'm interested in research, but I don't really know if that's the path for me. And I worked for 2 years in health education. And during those 2 years, was able to do a little teaching and thought, oh, actually, yeah, this is checking up some boxes. And I then went back and did my doctorate, and then went into a postdoc at UC Irvine. Fast forward a little bit, I've had the pleasure of being at two institutions. One is yours at Cal State Fullerton as a professor in what was called then the Department of Health Science. And that I was there for 15 years, and I loved that work. Being able to work with ESG, with the communities you serve, and the wonderful advocates that are on campus and off. And then 6 years ago, I came back to UCI where I did my postdoc to now serve in the Cancer Center and as the Associate Director for Cancer Health Equity and Community Engagement for our NCI designated Comprehensive Cancer Center. I say in a way, it's all just been circular. My fundamental mission is where can I be in order to make the most impact in the communities I value. So now moving forward, I just want to say that with a doctorate and actually with a master's too, I felt very ready to start thinking about data and how we might be looking and using data for good. And so one of the things that I do at UCI is I look very deeply at demographic data, social, behavioral, and cancer data. And so, for instance, I hope all of you know we are in a wonderfully diverse county, Orange County with 3.2 million people. We are a majority county, and we've been this for, I think it's since 2015. So the largest groups are still non-Hispanic whites in yellow, but you can see our Hispanic population of 34% and Asian American population 21%, as well as other groups, total more than 50%. And for instance, we have the largest population of Vietnamese Americans in the country. Now, we oftentimes look at the deficits, and so here are some data on deficits. What do these populations, for example, Hispanic and Asians, what do they face? And so if you look at the blue and green bars compared to the yellow and orange bars, you can see we have larger proportions that are foreign-born among Asian Americans and Latinos, limited English proficient, to some degree, lower educational attainment, higher levels of poverty, and higher levels of lack of health insurance, or what we think of as poor quality health insurance. Okay, so oftentimes I get asked, well, why did I work on cancer? And my quick answer is the following. When we look at leading causes of death, and I'm very interested in our ethnic racial populations, that is my experience, that's what I've observed, the kind of the communities I want to serve. You think, well, what are they dying of? Well, when you look at non-Hispanic whites, I think you can see by this table, the leading cause of death is still heart disease. But when you look at all other groups, and I'm now showing you Latinos, Asian Americans in aggregate, and Pacific Islanders in aggregate, you can see it's cancer. And I have gotten very adept at being able to relate almost anything to cancer. Because if you're interested in prevention and healthy behaviors, cancer, they're usually things that can help prevent cancer. If you're interested in mental health and well-being, these are absolutely issues that affect either cancer screening and kind of cancer stigma and or survivorship. And when you look at, for example, screening in particular, you can find, and again, we're looking at the blue and green bars, the Hispanic and Asian Americans. When we think about like, well, who's getting screened and who's not, you can see for lack of mammograms, it's higher among Hispanics. Lack of colorectal cancer tests, that's higher among Asian Americans. And if you look even further, and I'm sorry, you don't need to look at any of these, but if you look at any of the markers, the things for disaggregated Asian American groups, you can see that they're all lower in terms of cancer screening based off of the Healthy People 2030 guidelines. So really, what we're talking about are working in the area of cancer health disparities. And so the National Cancer Institute has a definition for this. It's a pretty general definition, I will say. And it's essentially any ongoing differences in the rates of cancer, the deaths from cancer, or the risks for cancer by different groups. Here is an example by race, ethnicity, and gender. So for example, we know African-American women are at higher risk of being diagnosed with triple negative breast cancer, which is a very, very aggressive form of cancer for which we do not have good treatments. And thus they are more likely to also die from breast cancer. We know that Asian Americans and Alaskan Natives and Pacific Islanders have higher rates of liver cancer than other racial groups. And that's not just women, that's also men. And we know that cervical cancer, now again, this is for women, is higher in rural areas than in urban areas. So, sorry, not higher, that women in rural areas are more likely to die from cervical cancer compared to urban areas. I do want to say that the National Cancer Institute and researchers don't just look at race, ethnicity, or rurality. They also look at income, sexual orientation, gender identity, disability. And so when we think about what those populations are that could be experiencing disparities, again, racial ethnicity, low income, lack of health insurance, and members of the lesbian, gay, bisexual, and transgender community are groups that I have been collaborating with and working with to understand risk and what we can do to improve well-being. Okay, and so part of the thing is, well, why do these groups have higher rates of cancer and or lower rates of screening, higher risk, et cetera? And the short answer is we know a little bit, but we don't know everything. And so I gave you some clues to this when we think about things like discrimination, things that my family has experienced. We are starting to get clues that discrimination leads to stress, leads to greater inflammation, sorry, and that means greater risk for cancer. We're starting to understand a little bit about those pathways. So, but in general, the buckets that we look at are environmental, behavioral, social, clinical, cultural, psychological, and biological. And right now in my research, I'm focusing very much in these 4 buckets. We know that, for example, biology and genetics plays a role. I don't do that kind of research. On the other hand, we just got funded to look at climate change and how that might be influencing cancer screening. So especially heat and wildfires. How does that limit or change people's desire to get screening and access to actual screening when they are eligible? And, I think I just mentioned this, there are models for how you look at all of these different contexts. So you can think about the neighborhood physical environment, as part of environment, but you can think of, community and social contexts. And we've talked a lot about like social support and integration and systems of care, for instance. And I just wanted to say, so this is a model that comes from the Kaiser Family Foundation. This is actually an old model. I'll apologize because what they've actually added to this explicitly is racism and discrimination, which you do not see explicit here. So their updated model includes that. But when we're talking about these kinds of impacts, we know that they account for 50 to 60% of health outcomes. That means that if we can work in these areas, these are public health areas, we have the opportunity to really contribute to the well-being of populations and communities. Okay, so now I'm going to switch gears because I think one of the things that I should say, even as an undergraduate, you are getting fantastic training in data that I never had as an undergraduate. So what can you do? How are you using these skills? And what can you do to be able to either tell a story about the need and or use that data to inform the things that we think that can work in communities? So the last part, the rest of this brief talk is going to talk a little, just some snippets of examples of the ways that I have worked with others to use data to tell a story and or to address a community need. Okay, so, and I got 3 examples. So the one is actually we're partnering with researchers to use data from the California Cancer Registry to understand disparities in access to care. So we started with the question, is there a difference in the stage of diagnosis of cancer among people of different races, race, ethnicities, and among people with different insurance. And what you can see is the easy answer is yes. For when you look at breast, colon, cervical, liver, and gastric cancers, less so in terms of gastric, but you can start to see some of these differences. And you look at just the stage of diagnosis, you can see that compared to non-Hispanic whites, every group that has indicated with a percentage in red means a higher proportion were diagnosed at stage 2, 3, or 4 compared to stage 0 or 1, which are considered early stages. And this is an inequities in access. You can also see another indicator of this, which is insurance type. Now, you would think if you have health insurance, shouldn't you all have, access, equal access, or at least, ability to get screened and find cancers early? And so the answer is, well, if you've got private insurance, then you have the lowest proportion of later stage cancers. And you can still see that there's some challenges here. So colon cancer, for example, tends to be later stage diagnosis, despite that a colonoscopy can actually prevent colon cancer. But you can see the two insurance one is Medicaid, which is what we call health insurance sort of for low income. All of them have higher proportions of later stage. And of course, you can see for uninsured, for all cancer types, we have later stage. To me, this is not only disparities, these are inequities. We live in a time that people should have easy access to all of these screenings. Gastric and liver, we can talk a little bit about, but breast, colon, and cervix for sure. These are USPSTF recommended screenings. These are covered. If you have Medicaid versus private, these are covered screenings. There should be no differences, and yet there are. I want to show you another way that we've looked at screening. And again, this is a lot of data, but I find this fascinating. We also looked, well, among people who were screened, have cancer, regardless of when they were screened, did they get the care that is recommended? So now we're thinking, by ethnicity, race, did they get quality care for their cancers? So now I'm going to show you, and I'm sorry it's going to flip. Cancers are going to be on the column, the row headings, and ethnicity on the column headings. But now you can see again that by breast, colon, and liver, you can see actually some groups were more likely to get good care. So for example, Filipinos for breast and colon, we found a small but statistically significant higher likelihood that they were going to receive, and in this case, quality care is defined as NCCN guideline adherent, National Comprehensive Cancer Network, NCCN. But you can see the groups that are less likely to get quality care. So that's Latinos. For breast and liver, they were statistically less likely to get NCCN adherent quality care, and Chinese for colon and Koreans for colon. So now you think, well, no, wait a minute. We've got standards for care. Doctors are trained on standards of care. Why are people getting poorer quality? We've used this data to advocate with our Medicaid managed care in Orange County. And for some of you, you might have heard that last year, CalOptima launched a $50 million initiative to improve cancer screening among people with Medicaid in Orange County, to do it targeting ethnic racial groups, and to ensure to see and improve the receipt of quality care for those who are diagnosed with cancer. This is a $50 million 5-year effort that has already started last year. And we're going to be replicating all of this data to show if that's actually happening in Orange County. Okay, so I know I want to get through a few more so that we have time for our second speaker and then questions. But another way that we've looked at disparity is to say, okay, well, let's think about less about who are, what we look like, gender, race, ethnicity, income, et cetera. And let's just look at geographically. Can we find essentially hotspots where people are lacking access? So this is data from the Centers for Disease Control. This is actually data that all of you can go to if you go to places. So cdc.gov/places. You can noodle around with these fantastic mapping programs. So for example, mammograms. It turns out, and this is a map of Orange County. So this is a heat map. The darker the color, the higher the prevalence of the cancer screening. So dark blue means a higher prevalence of mammography use, and lighter blue means lower prevalence of mammography use. So you can see that the lighter the color, the less that they are actually accessing a cancer screening. And it's in North Orange County. We're thinking about the cities of Anaheim, Garden Grove, Santa Ana. And is anyone surprised that I can show the exact same thing for cervical cancer? I can show you the exact same thing for colorectal cancer. This is not an issue of individuals deciding not to get care. This is about the fact that there are hotspots in our county where people have difficulty accessing this care, and it is North Orange County. We have used this data to basically work with our federally qualified health centers in these areas to increase their screening of their patients. So we worked with the UCI Federally Qualified Health Center and which primarily serves Latinos, and Southland Integrated Services that primarily serves Vietnamese, and Korean Community Services that primarily serves Koreans. And they're located in these areas to increase the screenings. Okay, so another example of data. The third example of data is, okay, let's actually start looking at screening data in clinics. So this is the data from the UCI Health Federally Qualified Health Center. This is called the UCI Family Health Centers. And there are two locations, one in Santa Ana and one in Anaheim. And so we thought, well, and again, this is data that you can actually get access to from the Health Resources and Services Administration, or HRSA. And these are called the Uniform Data System, or UDS measure of performance. So you can see that they vary by the proportion of screenings of patients that are getting screened. So these are eligible patients who are eligible for cervical, eligible for childhood immunizations, eligible for breast cancer screening, eligible for colorectal. And you can see that we do the best job, but not great. Only 60% of their eligible patients are getting cervical cancer screenings versus 47% breast cancer and 45% colorectal. And what we've used are these dashboards over the years to track impacts in the work that we're doing to improve their screening rates. We've also helped them get a mini grant from HRSA called Accelerating Cancer Screenings in order to work specifically on this and hire a community health educator who's dedicated to this work. What we found is that when we work with clinics and we show them these dashboards, we're actually able to engage with them on how they can improve cancer screenings. And here's some of the things that they do. They look at their workflows to find out where are the barriers to the recommendations. They initiate patient reminders because we're told by our doctor that we need a screening, but there are many reasons why we don't get it. So the patients are recontacted. We provide education followed up with instructions. For example, colorectal exams, it's a little tricky. You go home with what's called a FIT kit, and you're supposed to essentially take a sample of your stool, smear it on this kit, and send it in. It is a little tricky. And so how do we get that to their patients, and how do we follow up so that they know how to do it in the language that they speak? And then using the Epic, this is our electronic health records MyChart app to remind patients and to communicate with them about their adult results and next steps. And through this work, and this was, I'm sorry, a little dated, but we were able to show that over just 1 year of doing this work, we're able to increase screenings. And by the way, what I think is remarkable is this is during COVID. So in the midst of COVID, we were working with clinics that were being inundated with people who wanted, for example, COVID vaccinations or who needed COVID testing and treatment, to also work on cancer screenings, because they knew that if they don't do that, that once the COVID pandemic becomes more open, I'm not sure we're actually going to ever be out of the actual worldwide pandemic issue concern, then that cancer remains the leading cause of death for their patients. And so they were willing to do this. They responded to the data that we were able to show, and we were able to track it and show really important improvements over time. Okay, so I'm just going to, so I hope those are 3 examples of data that either you can get access to, or, in some respects, you're going to have to collaborate with others, but to really tell a story and use it to help improve services, reduce barriers, et cetera, for the communities we care about. In the last few minutes, I'm just going to talk a little bit about data is fantastic, but if not used right, it can also harm. And what do I mean? When we look at cancer, as just an example, and this is cancer incidence, we could be looking at any kind of thing. What I'm concerned about is this category. This is a nonsensical ethnic racial group. Asian Pacific Islanders represent dozens, of different groups with different cultures, languages, immigration histories, oppression and policies against them, economic. I mean, if you think about someone who came from East Asia as a immigrant versus someone from a war-torn area as a refugee, very vastly different resources. Why do we continue to put these groups together? And, in a nutshell, I hope all of you in public health know that when we aggregate groups together, we mask the differences. So much so that now it looks like Asian Americans have the lowest rates of new cancers among all groups, and we know this is not true. There are some websites that you can go to that are trying to disaggregate. So if you go to this explorer.ccrcal.org, you can see that they disaggregate Chinese, Vietnamese, Japanese, South Asians, Filipinos, and Koreans. And this is for all cancer sites combined in terms of incidence 2000 to 2015. And you can see that the groups with potentially the lowest rates of cancer, now this is all cancers, look like South Asians, but the groups that have the highest rates look like to be, for example, Japanese, although if you look at the lines, you can also see that we've got some concerns about Vietnamese and Filipinos too. If you look at mortality rates, you can also see differences by ethnicity these are only Asian American groups. We cannot find this data readily accessible for Pacific Islanders. And I want to just highlight what some, physicians and researchers have said, that for Asian Americans, and I added for Pacific Islanders, progress begins when we recognize the diverse experiences, when we provide data that's relevant to the subgroups, and we fight against this omission or this aggregation. In fact, they talk about the fact that it's essentially a form of systemic racism when we put all groups together in order to mask the differences between them. So one of the things I am very reminded of is we saw this happen in real time during COVID. When we had in 2020, the COVID was declared a pandemic. In September 2020, only 46 states reported cases and 36 reported deaths for Native Hawaiians and Pacific Islanders. 16% aggregated Pacific Islanders with Asians, and 38% reported Pacific Islanders as others. What did this lead to? Well, it led to the fact that we were not paying attention, in this case, to the Native Hawaiian Pacific Islanders. And so people were, for example, producing these dashboards that showed that compared to the population in the light blue, the proportion of the group in the population, the proportion of cases in that group seemed higher and disproportionate for Latinos and Blacks, in that a higher proportion of the population were affected by COVID compared to their proportion in the actual population. But what we found very quickly is once we started looking at the NHPI data, this is the Pacific Islander data, we were finding rates of deaths that were nearly equal to Latinos. And this is, again, I think this is back in September 2020, when we were starting to finally get the data. We were finding that Native Hawaiian Pacific Islanders were dying, and they were being completely ignored. And so once again, it's this quote that says, all systems collecting race data should be collecting data for Native Hawaiian Pacific Islanders separately than from Asian Americans. This is the same call to action that's been going on for decades, and we just saw it replay completely. Actually, I knew there was a reason why I didn't have the updated Kaiser Family Foundation, is because here is the revised. So as of, I don't have it, but I think it's as of 2020, they included this race and discrimination as cutting across all of the determinants of health. And if we must be paying attention to how racism and discrimination affects, not just in terms of what we normally think of as discrimination, exclusion, systemic policies, access, et cetera, but also insidious when we think about data. And, this quote is, viruses do not discriminate. And so nor should health systems, nor should our data systems, nor should any of us. We should be striving to better understand so we can better address needs in communities as they happen. So I just want to end by saying, as a public health person, I love, let's just say, spending time thinking how we could be improving our data. And so I think I'm not sure if I dream all the time, but this is some of my life's work, is to make sure that we're getting data. I've shown you some of those examples that are disaggregated, putting it in front of stakeholders and making sure that they do right by our communities. We do not want a repeat of COVID. We do not want a invisibility of communities that are suffering and or that are needing more support, funding, public health collaboration and capacity in order to meet the needs that they see in real time. And with that, I will end. Thank you very much.
Great. Thank you, Dr. Tanjasiri. Your work is truly inspiring and has had a significant impact on the community. Now I would like to invite our very own club advisor, Dr. Lohuwa Mamudu, who is also an assistant professor in the Department of Public Health at Cal State Fullerton. And you will have until 11:50 to speak, Dr. Mamudu.
Okay, there you go. I never knew I am muted. Okay, thank you very much, Brittany, and thank you, Dr. Sora, for such a impressive presentation. I think you've set the ball rolling for me, because I'm also coming to talk about cancer disparities as well. And I must tell you that Dr. Sora have actually been a great mentor to me as well also. So it's nice presenting on the same platform on the same subject with her. Yeah, so and then before I go on, I always want to see people smiling and laughing, because you never know when you smile, you make people day, right? Which is also a matter of emotional well-being. So I want to see everyone smiling and waving at me. Okay, all right, thank you very much. So what I'm coming to talk about today, I'm actually looking at I'm actually going to look at disparities in lung cancer treatment, and then also the link between cancer and mental health. So actually, I have been working interdisciplinary field. So I work on cancer, I work on mental health, I work on even different chronic diseases and stuff. So I try to see how much I can connect these pieces together in different research. So I will go through some cancer treatment disparities when it comes to lung cancer by connecting you everyone to the national database. And then I've been actually collaborating with NIH and then the Tennessee Cancer Registry. So I may not be talking about California cancer data, which Dr. Sora have already done, but I'm also going to connect you guys to a different database, which is Tennessee Cancer Registry data, and let you know certain findings in that regard. So we will talk about some lung cancer disparities, and also some research findings which have been actually done on lung cancer treatment disparities, my own research with my collaborators, and then also we will look at cancer already and then mental health, and then also some research on that, and then we'll actually conclude. So I'll try as much as possible to wrap up very fast so that we can have a break for our student presenters to continue. Okay, so now let us actually look at some few backgrounds when it comes to lung cancer. So just as Dr. Sora echoed, lung cancer, of course, is the second leading cause of death in the United States. And then you can see right behind heart disease. So it tells you how much lung cancer in general actually impact the United States. And then more so, when you take cancer as a whole, lung cancer tends to be the highest cause of death among all the cancer diseases, in the United States. So here is a data on lung cancer, which is actually projecting the death of lung cancer by ages, which I hope I don't scare any of you, but however, if you look at the lung cancer by ages, you can see that those who are 65 to 74 years tends to actually die more from lung cancer. And then also, fortunately, the youth are not actually that much over there, but you can see the death toll actually increases with age, which have been the scenario when it comes to actually cancer studies and lung cancer in particular. So I did spoke about Tennessee Cancer Registry, and the reason for actually, I was in Tennessee in 2016 to 2017 before I moved there from there to Florida, and I have been actually working with them since then. And if you look at Tennessee, it tends to be a state in which tobacco use is very prevalent. And so to that point, if you look at the incidence of cancer in Tennessee, you can see that Tennessee is almost right at the top there, which is about by far higher than the national incidence rate. The national incidence rate is given by the light green you are seeing, and then you can see Tennessee here, which is very high, which is about, I think, the fourth when you look at the entire United States. So it tells you how much lung cancer is actually prevalent in Tennessee, and they need to actually look into some of the issues when it comes to lung cancer in Tennessee. Now, let me just give you a little bit of a picture when it comes to lung cancer. Of course, we have two types of cancer diseases. When it comes to lung cancer, we have the non-small cell lung cancer, and then we have the small cell lung cancer. The non-small cell lung cancer is the most prevalent lung cancer. And what you should know about the lung cancer is the fact that it is more treatable at the early stage of the cancer. But unfortunately, usually the detection have not been very common. And I'm going to show you some figures on that. And so, and most people, before they are being diagnosed by their cancer, it would have already metastasized to other part of the lungs, which actually make treatment quite difficult. Now, this is a data which was actually projected by the American Cancer Society on the survivor of lung cancer by the stages of the cancer. So we have, if you are diagnosed at the localized stage with a non-small lung cancer, you have approximately that's 63% 5-year survival rate. And then the rate continue to go down as the stages of the cancer increases, which is something. So overall, lung cancer overall, in terms of the non-small cell cancer, we have 45%, 25%. That which was a data from 2010 to 2016. Now let us look at the small cell lung cancer, which tend to be a very aggressive type of lung cancer. So if you are diagnosed with a small cell lung cancer, it has the tendency to actually move very quick to other part of the body. And you can see that if I should go back a little bit, you can see for the localized stage, which is the early stage of the cancer. So the localized stage, the localized stage can be evasive, but the spread have not actually happened yet. And you can see for non-small cell lung cancer, it's 63%. And then for a small cell lung cancer at the same localized stage, it is the survival rate is 27%. percent, which is also a data which was actually projected by the American Cancer Society. And then you can see the overall survival rate of small cell lung cancer, which is 7%, as opposed to the non-small cell lung cancer, which was 25% overall. Now, let us look at some data when it comes to, Tennessee cancer, and then also based on the stages of the cancer. So you have the dark blue, which is the localized stage or the early stage of the cancer. You have the pink, you have the green, and then should I call the sea blue? I'm not very good at color, so forgive me. Yeah, so you can actually see that here, which is the light green, which tends to be the distant stage of the cancer. Most people are being actually diagnosed at the distant stage of the cancer. Now look at it. If you are diagnosed at the distant stage of the cancer in Tennessee, there's the survival rate, the 5-year survival rate, which is just 6%. So it tells you how serious it is if you are diagnosed with lung cancer at the distant stage, right? And that makes screening very important, which we'll come to talk about that and then you can see the survival rate actually increases at the early stage of the cancer, which is you have about 60% increase in terms of your survival rate 5 years relatively. So, and this actually 2021 data by the American Lung Association. So now, the good news is that if you actually happen to be diagnosed at the early stage of the cancer, there have been studies which have been published that at that early stage, you have about 70 to 90% 5-year survival relatively, which is very impressive. But that always the problem now become how then are people get the chance to be diagnosed at such an early stage, right? And we will be getting there where we are going to actually link these pieces to what actually causes people mental health when it comes to actually cancer problems. Okay, so now let us link this to our research findings where you have the different stages of the cancer. And then of course, with the different stages of the cancer, like I said, the increase, while the cancer stages increases, it means it become a spread to other parts of the lungs or the body, which make treatment quite difficult. So we actually use a 2005 to 2015 Tennessee data to actually evaluate this. And then we are looking at actually the surgical treatment of cancer. Now, surgical treatment have been a very effective treatment for lung cancer. As I actually showed before, surgical treatment can actually yield about 70 to 90% survival rate 5 years relatively. So our aim was to actually look at what are the factors that influences surgical treatment of lung cancer, and then what are some of the disparities among these factors. And we are looking at it from socio-demographic point of view, from health insurance point of view, and others. So we examined the disparities of surgical treatment of lung cancer, and then also the time to treatment initiation of lung cancer. Both of these two components are very important because since we know surgical treatment is a very effective treatment for lung cancer, especially at the early stage of the cancer, so are the time to treatment, because the time to treatment, we are looking at that the range from the time the individual was diagnosed with the cancer and then the time the individual actually started their treatment. So if you delay the time, then there's that tendency that your cancer may end up metastasized to other part of the body, making treatment quite difficult. And the more it metastasizes, the lesser your survival rate, right? So we actually, using this Tennessee Cancer Registry data, we actually look at what are some of the likelihood of surgical treatment of the localized stage of the cancer specifically, because we would want to know and inspire people, hey, this is how it looks like if you are diagnosed at the localized stage of the cancer. And that is actually also a means of promoting people to go for screening, which by screening, the more you screen, the more chances that you are going to be identified at the early stage of the cancer is high, right? Although people may have different opinion when it comes to actually screening the type of tool which is being used for the screening. So here are some of the findings we actually came up with. So we actually compare male and females, right? And then with our males being our baseline or the reference group, we find out that females are 1.14 times more likely to undergo surgical treatment for the lung cancer when being compared to males. And then we also look at it by age. So interestingly, and this could be a positive news for the young adults, but it also could be a very negative news for the aged group, because we are seeing that for the young adults, which is less than 45 years of age, they are more likely of surgical treatment for lung cancer. And then it continues to decrease whilst the individual ages. And using our 75 years plus as our baseline, you can actually see clearly how the decreasing actually goes. So it could be a good story for the younger group, but the adult, and the reason for which the adult group do not undergo surgical treatment, there could be several other factors which may be considered, but that's something also a debate that could be had as to why those aged group refuse to go for surgical treatment of lung cancer at the localized stage, even though surgical treatment tend to be very effective at that stage of the cancer. And then also, we also look at the receipt of the, again, we actually look at it by race. And then we look at it just by only white and black. And then one may ask why only black and white in Tennessee. Now, predominantly Tennessee geographic in terms of population is more of whites and then more of blacks, and only few of other racial groups. Yeah, sometimes at a certain point during the time this data was collected, they were not even up to 0.2%. So they were just drawn out of the data and just focus on the black and white within Tennessee. And you can see blacks are less likely to undergo surgical treatment for lung cancer at the localized stage of the cancer when being compared to the white folks. And then also, we also look at it from marital status point of view, because sometimes marriage can be very positive. Sometimes it can be also, it may not, right? Yeah, so we are looking at considering different marriage group, how much an individual is likely to undergo surgical treatment for the cancer. And you can see that majority of whom are, which was very surprising, are divorced and separated, are even more likely to undergo surgical treatment for lung cancer. And then, of course, married and then widows, they are also more likely to undergo surgical treatment for lung cancer when compared to the single group. And then, so, I mean, that's a question to also ask why people who are not married perhaps are not willing to undergo surgical treatment for lung cancer at the localized stage. So we also have for the Appalachian and non-Appalachian Tennessee. And then again, in Tennessee, there are two regions. So we have the Appalachian County and non-Appalachian County. And then the Appalachian County tends to be socio-economically disadvantaged as compared to non-Appalachian Tennessee. So by comparing these two groups, we found out that the Appalachian Tennessee are less likely of surgical treatment for lung cancer when compared to the non-Appalachian Tennessee. And then also, we were also very much interested in looking at what about the time to treatment of the cancer. So we look at it actually from using the median time to the localized surgical treatment for lung cancer. And then we have individuals who underwent the treatment beyond 2.7 weeks and those less than or equal to 2.7 weeks. And after 2.7 weeks, it seems like people are more hesitant to undergoing surgical treatment, which means they are less likely to undergo surgical treatment for lung cancer. Well, I don't know. What I don't know is the fact that which clinically, whether this actually is logic given 2.7 weeks, but actually that's what the data is actually telling us. So in some implications of the findings in which we have, or the fact that Blacks and those residing in Appalachian Tennessee are significantly decreased likelihood of receiving surgical treatment. And then one of our proposed recommendations is developing some treatment policies that target Black communities and areas of the Appalachian region of Tennessee to minimize the racial disparities in surgical treatment of lung cancer. Then also we know the patient with private and public insurance, which I think maybe I didn't show that data, where also have both of them have increased likelihood of surgical treatment of lung cancer. But however, we found out that private insurance were more likely to undergo, individual with private insurance were more likely of undergoing surgical treatment of lung cancer. So increasing as a policy proposal or recommendation, we recommend increasing the number of public health insurance providers such as Medicare and enacting policies to reduce the high prices of lung cancer drugs and also help reduce waiting time to receive recommended surgical treatment. So now let us also look at, we also were looking at the time to treatment initiation of the cancer, which is also another important piece in terms of the survival of the individual. So using the same Tennessee data, we actually look at it from, given that in our previous slides, I did spoke about time to treatment of lung cancer and the fact that people are less likely to undergo surgical treatment beyond 2.7 weeks. So we actually look at it, we actually perform a subgroup analysis of Black and then whites, and then rank the risk factors, these risk factors, to see how likely are individuals to delay their treatment beyond the median of the data, which is 2.7 weeks. And then by ranking them, so for the whites, you can see we have the married group were more likely to actually go beyond the 2.7 weeks of undergoing, that's more likely to delay treatment, which is going beyond 2.7 weeks, followed by less than 45 years private insurance. And then lastly, we have the localized stage of the cancer, of course, which is very good. At the localized stage of the cancer, if you are less likely to delay the treatment, it is really good. And there's something similar, which was actually also pictured for the Black population, which unfortunately in Blacks who are less than 45 years are more likely to delay their treatment, which given that in the earlier slides, I did mention the fact that those youth or less than 45 years, these individuals are more likely to undergo surgical treatment. But when it comes to the time of undergoing the treatment, Blacks folks are more likely to delay the treatment, which is less than 45, which is something to actually look into. And then we have followed by the widow private insurance, which is pretty much similar to that of the white patients. And then also we have in that order. So these are all ranking the possibility of individual delaying their treatment from the highest, those who are more likely to the least of delaying the treatment. And then also, we also try to make some comparison between the white and then the Black to see, considering all the other risk factors, which was actually shown in the previous slide, how likely is Black undergoing surgical delaying their treatment, and how likely are whites to delaying their treatment. And then you can see clearly we have the black line, which is the red line overlaying on the blue, telling us that, which is, there is no much bigger difference, but actually it is actually telling us that there is actually Blacks are more often likely to delay their treatment. So also with that, patients in the Appalachian region, of course, were more likely at risk to delay their treatment, and then at risk. Yeah, so as a proposal, we also said interventions such as local community resources and then also telemedicines may be adopted, which have been something which have been adopted in the past, which have actually helped, something like telemedicine, where people doesn't have to walk in, but they can actually receive some form of treatment online. So so overall, we actually look at the fact that we said that given the stratified subgroup analysis, we find out that Black population were actually at greater risk of delaying their treatment for lung cancer, and And as a policy implication, we propose the fact that we know that Blacks in Tennessee and more often the Appalachian region are inadequately affected by healthcare, and then also low income, so low education, and then other least life expectancy. And this issue, when addressed, can actually help increase the time to treatment of the individual with lung cancer. Now, just to actually, I'm about to end the conversation, but now let us look at connecting cancer with mental health. So let's say cancer worried and then mental health. So my question to you is, how do you feel when you hear about mental health? Please, can you put it in the chat? If assuming you hear about a friend of yours is having, let's say, a cancer, or maybe there is a cancer history in your family. So how does it let you feel about cancer? So you can put it in the chat if you wouldn't mind your feeling about cancer, if you hear about cancer. Yeah, so someone says sad, broken, heartbroken, scared. Yeah. Yeah, absolutely. And these are some of the things which actually pop up when it comes to hearing about cancer. Cancer, of course, we know is the most stressful and then anxiety-provoking and fearsome disease, especially given that when diagnosed with cancer, it is right behind heart disease in terms of your death rate, which it has a very high amount of death toll in the United States. Then also cancer patients are historically at risk of getting cancer when that's at risk of getting cancer and have actually shown a higher risk of mental health issues such as depression and anxiety. Now, there's actually a data which I actually collected from the website, Here to Save, a group of health specialists who actually deal with cancer and mental health. And then you can see they talk about 1 in 3 cancer patients experience mental health problem. And then also 50% of all mental patients will experience anxiety and depression. And then 1 in 10 patients need intervention for psychological specialists in the year. And then also your cost also increases as mental health issues increase the health care cost up to by 45%. And there's actually the link if you would actually want to look into. So here are some data which actually talks about cancer. Now, what you should know is getting worried about cancer can actually have some positive impact and can also have some negative impact as well. So for instance, there are people who talk about the fact that they are worried about cancer, breast cancer, allow them to actually obtain their mammogram, right? And then also, on the other hand, the fear of being testing positive is something which also drag them away, right? And then also cancer worried have actually resulted in distress and then avoidance of screening. So there are some positivities associated with being worried about a cancer, but more often the negativity actually outweigh the positivities, which I will come to actually look at it in a shortly, and I'm almost wrapping up. So it said cancer significantly affect the quality of life of individual and their existential concerns, including anxiety and depressive symptoms. And then what you should know is cancer doesn't only impact the patient, but it also impacts their immediate family. You know, the anxiety they go through, the sadness, sometimes the anger of having been diagnosed with cancer is very huge. So here is a research in which we actually did on cancer worried. We actually look at how much does cancer worried impact the depression symptoms or the depressive symptoms of an individual. And then, so we examine the cancer worried and its interaction with age impact on an individual depressive symptoms, and by comparing male and female as well. So in our results, you can actually look at it. So, So what you can actually find here is the fact that given the depressive symptoms of the individual, the more depressed the individual is, relatively, if you compare if you compare male and female, that if you compare male and female in terms of their cancer worry, then you can actually see that the severity of cancer worry for male and female, for females continues to increase relatively when compared to males in terms of their worried about the cancer, and then also their depression level. So their depression level actually increases when worried about cancer when you are comparing male to female. Then also another findings in which is also quite interesting is the fact that by considering other factors which include the socio-demographic, socio-economic health behavior of the individual, we actually came to find out that no, indeed, men are actually more likely to be faced with depressive symptoms when worried about cancer than females, which is actually shown. Although both male and female are more likely, but we can see males are showing 2.44 times of having depressive symptoms when worried about cancer compared to those who are not worried about cancer, and then you can see that of the female. So now we also did something here where we said, okay, given the age of the individual and given the fact that they are worried, how much does that impact their level of depression? And then you can see that for males, those 50 to 64 years who are impacted by cancer worried are more likely, are 2.51 times more likely of depression. And then we have for females, those 35 to 49 years, how do you call it? That 1.67 times more likely of depression symptoms. So here is some actually policy implications, which we actually highlighted on based on our findings. The fact that both male and females are more likely to be faced with depression when worried about cancer, although we find out that males are more likely to face depressive symptoms when worried about cancer than females. Maybe probably also because of the prevalence rate of cancer are more likely to be of males than females. Then also the study highlight about the complex interplay between age and gender, and then also cancer worry in relation to depressive symptoms. Then by understanding these processes, it actually helps us to be able to know the high risk group of depressive symptoms, to be able to actually address issues of depression when worried about cancer. So in conclusion, here is some of the coping skills when it comes to cancer anxiety, and then also lung cancer, which I actually took from this website as well, which you name your anxiety and identify the triggers, manage your stress, eat a healthy diet, exercise within your limits, try relaxation techniques, find social support, and also consider medication. So these are things which actually help an individual cope with their issues of depressive symptoms. Okay, so thank you very much.
Thank you, Dr. Mamudu, for sharing informative research on lung cancer disparities. So due to time constraints, we will actually be skipping over our Q&A session, and therefore this will actually conclude our second and last session of our guest speakers. Truly, on behalf of the ESG board, directors, and students, thank you to all of our guest speakers for your motivational and experienced talks. On that note, we will now be taking a 15-minute break before we move on to our student presentations. So please return at 12:20 for our student presenters. Thank you.